Welcome. Good afternoon, everybody. My name is Jane Schlaze. I am here on behalf of the Levy Senior Center Foundation. I'm going to be serving as your moderator this afternoon, and we are happy to welcome you to today's Levy Longevity with Sarah Chen. On a personal note, I had the honor of sharing my home with my mom for the last 9 years of her life. She had Parkinson's disease for over 25 years and kidney disease for her last 3. So I learned a lot about taking care of folks in the senior years with some serious challenges. I learned a lot about meds. I learned a lot about managing caregivers. And I know I have a lot more to learn, certainly as I think ahead to my future and elder care and training my kids to take care of me. So we are also very fortunate to have Sarah Chen with us here today. So without further ado, I'd like to introduce our speaker. Sarah is a licensed clinical social worker at Rush University Medical Center with more than 15 years of experience working as a clinician, as a program coordinator, and a research team member. She has spent her career providing care management in long-term care and ambulatory healthcare settings, where she worked to address the non-medical barriers to wellness and to improve healthcare outcomes for both the patients and the care partners, focusing especially on individuals and families that are impacted by the symptoms of various neurodegenerative disorders, as well as forms of dementia. So we are thrilled to have Sarah here with us today. I want to thank you in advance to those folks who submitted questions for today's program. Wonderful questions. Sarah will likely answer many of them during her presentation, and we have time at the end, dedicated time at the end, to answer many of your questions, if not all. I want to highlight that there is a Q&A feature at the bottom of your screen. Look for that little question mark in a box where it says Q&A. That is the feature that is there for you to use throughout the presentation to submit your questions, and we'll answer as many of those as we can at the end. We will not be using the chat feature nor the raised hand feature. That way we can focus on Sarah and her message and use that dedicated time at the end of the program. So just know those features are disabled. This Levy Longevity is made possible by the Levy Senior Center Foundation and the City of Evanston. And as always, we appreciate your support of the foundation, and as we continue to work to connect the community of older adults. So I'd like to turn things now over to Sarah and our program, Navigating Changing Care Needs and Anticipating Future Needs. Sarah, over to you.
Thank you so much, Jane. And thank you to the Levy Senior Center and the City of Evanston for having me today. I will hope to talk about, as we're talking about anticipating changing needs and anticipating future needs, we're going to talk about modifying living arrangements, whether that's in home or long-term care. We'll touch on maintaining a safe environment, mapping your journey, which is include some of the documents that you may want to consider completing, and then developing a crisis plan, or what many people call a just-in-case plan. So we'll spend our time together going through those, and then I look forward to answering questions at the end as well. But to start, to kind of ground us in why we're here, why is it important to start to think about these things now? Some of the anticipatory planning that we can do now can be really beneficial for both you, your care partners, and your family in the future. And it can be really helpful because it allows us to have some of those conversations about what your wishes and preferences for care or living arrangements, or, really the world is your oyster, but it allows you to share with those key people what your wishes and preferences are. These conversations can be really uncomfortable. And so if we can be brave and start to have some of these conversations. It also provides guidance to those people who might be making decisions on your behalf in the future, and it will help inform future decisions that someone might need to make. It also allows opportunities for your family or care partners, people who are close to you, to ask some of those uncomfortable questions that they may be wondering about and are unsure, how or when to ask. So being willing to have these uncomfortable conversations can be a gift that we give to our caregivers and our loved ones, and ultimately to ourselves as well. And so, how do we think about modifying living arrangements? This is one of the biggest questions that we get. I work in the movement disorders clinic at Rush, but I've worked in the ambulatory care for years. And often families, patients are not sure when it's time. We don't get like a sign that says, okay, it's time to start bringing in care. Or we might, but sometimes they're hard to listen to, and we're not sure. So some things to think about is if you are concerned to be left alone, or if your loved one, if you're a care partner or caring for a loved one and you're concerned about leaving them home alone, that might be a sign that we want to think about bringing in additional care. If you as a caregiver, or you as someone who is receiving care from a care partner, if you're noticing that that person is limiting the amount of time that they're out of the house, if they're doing the supermarket sweep where we're trying to go to the grocery store and be in and out and back home within a half an hour because we're scared about what we might find when we get home, whether our loved one has fallen because they needed to go to the bathroom while we were gone, or, we're just saying no to activities, invitations, seeing our friends, or even limiting attending doctor's appointments. All of those things are clues that maybe it might be time to think about additional help. If you're noticing that your loved one is needing more help with self-care activities or more supervision because there've been some cognitive changes and you're concerned, again, all clues. And a big one, if you as a family member or care partner, caregiver, are noticing that you're feeling more overwhelmed, more stressed out, you have a shorter fuse, you're not sleeping well, you're noticing changes in eating, sleeping, your own well-being, it might be time to also think about bringing in care, because your loved one only does as well as you do as a care partner. So taking care of yourself as a care partner is really critical, because it allows you to take care of these people that you care so deeply about. But we need to put on our oxygen mask first too, so that we can continue to care for those around us. And so then the question is so I realize I need more help, but then how do I know what kind of help do I need, or that I need? And so some things to think about are how much, with what, and when. Some questions to ask yourself. And so how much is this idea of how much care do I need? You may not need 24/7 care to begin with. You might need help a couple days a week, so that you know that you're going to have care in the house. And whether that's you as someone receiving care, you know that on these certain days, you're going to get help with a shower, or you're going to get help with meal preparation. And you as a care partner may know that on Tuesdays and Thursdays, I have a chunk of time when I can schedule appointments or run errands or go out to lunch or do whatever with some friends, whatever it is. But that can be really helpful. Thinking about what you need help with. We'll talk about how you can explore that. And then when. Do you need more help in the morning, getting up and getting going for the day? Does it make sense? If you're not a morning person and mornings are slower, but you maybe need more help midday or in the evening with dinner and getting ready for bed, thinking about being strategic about when you're having the care come in. And so thinking about with what, it can be really helpful to make a list of some of the challenging tasks and get input from others. So you may have stopped doing certain things and not even realized it. Or your family or friends or neighbors may have taken on some of these tasks for you. And so they can help contribute to this list of what are some of the things that you might benefit from having support around. And then try to think about grouping some of those tasks together. Is it that we're needing help with housekeeping and laundry? Do we need a caregiver for that? Or is that something that maybe a housekeeper that came regularly could support with? Or are you needing help with meal preparation and grocery shopping? Are you needing help, like I was saying, getting up and going for the day? Is it with more like self-care tasks, getting out of the bed, getting into the shower, getting cleaned up and getting breakfast, and just additional set of hands there in the morning to help? So trying to be strategic, do a little bit of planning. It might even look like you keep track of over the course of a few days. When is it that I wish that I had additional help? When is it that I get into a situation where I'm kind of feeling precarious about doing something? And then reflecting back, are you noticing that those are happening at a certain time during the day or a certain time during the week? Maybe you have more visitors on the weekends and less visitors during the week. So then maybe we need to think about the weekdays as being a time to bring in help, or vice versa. And so then we realize what we need help with. We figure out when we want to have people come. And then I get people who tell me, but I'm not sure what I'm going to do with the caregiver, the private duty caregiver that comes in. I don't want to feel like I have to entertain them. So it can be really helpful to make a list, a schedule. This is an example. This is a pretty rudimentary example, but take the items from your list and fill them in onto a schedule. And so that way you can say to the care partner, here are the things that I hope to have accomplished while you're here on these certain days of the week. And then there may be some extra things. Maybe you ordered groceries and the groceries are being delivered on a day your caregiver is coming. And that's not necessarily on the list of things or the schedule, but that's something that came on a day when your caregiver is there. Great, ask the caregiver to help put away the groceries. So you know that certain things are happening, and then periodically reevaluate this schedule. Reevaluate the caregiver arrangement. Is this enough hours? Are you feeling like it's meeting your needs for right now? Is it too many hours? You're realizing like, I don't know that I need someone there 5 days a week. Maybe we cut it back to 3 days a week. Or vice versa. Maybe you're feeling like this has been helpful-ish, but I don't think it's really meeting the full need. So maybe we need to expand it a day, add another day on, or add a few hours on. Nothing is set in stone. And so giving yourself that permission to reevaluate periodically and setting that up can be really helpful too. And so we'll go through a few of the types of home care. One of them, a most common one you may have heard of, is home health care. This is ordered by the physician, generally maybe after a hospitalization, where you're discharged from the hospital, returning home, and you're receiving nursing and physical therapy and occupational therapy. There's also an option for a bath aid. It's time limited, and it's really the time and services are around that specific, what they're calling a skilled need, this therapy services. So they're not necessarily able to help you with meal preparation, but there are people in and out of the house keeping an eye on how medically you're doing as you transition home. It's covered by the insurance, so that's a benefit, but the insurance then dictates kind of what these services looked like. Another option are homemaker services. These are services through the Illinois Department on Aging. They can provide things like, or support with things like household tasks. They may be able to provide support with covering the cost of an adult day program a few days a week, an emergency response system, home delivered meals, and even medication dispensers. So they can be really helpful. They are again, time limited. You would be evaluated by the Area Agency on Aging to determine, are you eligible for services? Do you meet the requirements? And some of those requirements both are physically, do you physically need the assistance? And they also have some eligibility criteria around assets and income. And so they would ask about that as well. But this can be something that supplements or is a nice way to help support people remaining in the home. Just as a heads up, this program is not designed to be able to provide 24-hour in-home care. The maximum amount of care people can generally expect to receive out of the Homemaker program is somewhere between 20 and 25 hours per week at the top end. Most people often start by receiving support a couple days a week. So just sort of generally setting some expectations as you go into this program. Another option is the Veterans Administration. If you or a loved one are a veteran, you may be eligible for services through the VA. And these services can be really, really useful, and certainly something that you want to look into. They can be a little bit of a heavy lift to get them going. There's often some initial paperwork that needs to be completed, and they're based on your length of service, where you served, and whether you served kind of during wartime or peacetime, and also based on your discharge status. So you usually need to be able to also collect some documents, including documents related to your service. And if you have questions, you can visit a VSO, a Veterans Service Organization. There are several in the city of Chicago near the Jesse Brown VA hospital in the medical district, but then they're also spread out across the county. You can also call the caregiver support line. The phone number is here, and ask more about how you might get some of the services going, what might those services look like, but they can provide some assistance with in-home care. And then an option as well are private pay. So as we've been talking, you're kind of noticing that some of these programs are limited or they have restrictions based on income or assets. And so for many people, they may or may not be eligible for these programs, or if they are, these programs may not fully meet their needs. So then we're thinking about hiring someone that we're paying for out of pocket. And there's two ways that you may go about doing this. You might hire someone through a private caregiver agency that comes to the home, and the agency finds the caregiver, the agency does the background check and scheduling and training, and you have a point of contact at the agency for more of the administrative or HR related things. And so you're also paying for the overhead of the support from an agency. Whereas you might also consider hiring someone privately. And my next slide will give you a little bit more of things to consider. But before we move on to that slide, hiring a private caregiver, you have more control over the hours and when you would want someone to come and what kinds of tasks you would want them to help with. That being said, if there are some more medically complex tasks that may have implications on the type of care that the caregiver agency is able to bring into the home, because they're bound by the rules from the state of Illinois. So just something to think about. But here are a few kind of pros and cons as you think about whether you hire someone on your own or you hire someone through an agency. Usually, if you're hiring someone on your own, you're finding them through word of mouth, whether that's from a neighbor who had a caregiver, or it's a family friend's adult child or cousin or someone that is maybe in nursing school and looking for additional work. And so they can come to your house a few days a week when they're not in class and help you. It sort of looks like that. And then you're paying them directly. And you figure out then some of those back end, what we might call back end accounting or logistical things, how to get a background check if that's something that is important to you, or you don't know this person as well and you want to have that confirmation, that comfort. And maybe it's also meeting with an accountant to figure out if you want to be paying the taxes and all of those things on the money. People do it all different kinds of ways. I'm not advocating for one way or the other. I'm more providing information of things to think about. And for some, they don't want to have to deal with any of that. And while going through an agency may cost more or have more restrictions, that takes care of a lot of the administrative stuff, and that just feels easier. And it's personal choice about what people are most comfortable with. Another thing people may think about are, how do we get creative? Can we find some help through a faith community or other service organization that we're a part of? Can we look for volunteers or create a care team calendar where we put a list of things that we need help with? Or you have an appointment next week and transportation would be really beneficial. Or if people could bring meals a couple days a week, or you fill in the blank. What are things that would be really helpful to have support with? And then when people say to you, I'd love to be able to help, let me know what I can help with. Well, sometimes that can be a really overwhelming question, because you're like, I don't know what I need help with. I need help with lots of different things, but it feels uncomfortable to ask you to bring meals to my house. You can say, thank you so much. I've actually created this calendar of some things that I might need support with. If anything feels comfortable to you, I'd be so grateful if you could sign up for something. It takes a little bit of the discomfort of the ask out of the equation. You've listed the things you need support with, and then this individual who's offered help can sign up for what feels kind of within their scope or within their kind of willingness when they made that offer. So that can be a useful way to be creative. Another option that sometimes are overlooked are adult day programs. These provide safe programs outside of the home. They're stimulating with activity aids, nurses who can provide medication. They provide meals, and they may also be able to provide transportation depending on kind of geographic boundaries around the centers. They may be able to be covered through Department on Aging through some of those homemaker hours. You can convert them or kind of trade them and say, you know what, I'd rather have the adult day program covered instead. And then you can utilize the elder care locator or the Department on Aging's website to locate various adult day programs. CJE in Evanston has a really well-regarded program that you can explore as well. They're located on Howard Street. But adult day programs can be helpful too. Sometimes people feel overwhelmed having a caregiver in their home. They live in a condo, or they're just uncomfortable. They're trying to work from home, and then it would feel really distracting to have their loved one and a caregiver in the house during the day while they're trying to work. So this is where an adult day program can be really helpful. You're getting that support and stimulation, and they're getting it in a group format. It's so much more than you as one person can provide at home. And they're getting out of the house, and you're still getting that respite as a care partner. So a nice alternative as well. And so then as we transition from bringing help into the home and we think about long-term care, one of the big questions is, when is it time to make a move? I don't have that answer for you. There's really no good time to do it. However, there might be some better times and some more challenging times, but either way, you can make it work. Some of the things that might prompt someone to make a move is they want to reduce some of the housing responsibilities, whether they're a renter or a homeowner. They don't want to deal with the responsibility of making sure this time of year that the leaves get cleaned up, and there's the threat of snow, and they don't want to have to shovel their sidewalks. Or honestly, they're probably not shoveling their sidewalks, but arranging for someone to shovel the sidewalks for them. Or they don't have to deal with it when the furnace goes out and be responsible for figuring out how to get the furnace fixed. So those are things to consider. Another thing is reducing the caregiver burden or illness. If you're noticing as the caregiver that your health is compromised or you need to have a medical procedure, I'm sorry if you're seeing all these pop-ups on my screen. Okay. That maybe it is something where long-term care can be a benefit, that it might be time to transition into a facility. You're also noticing that there's changes in your loved one's care needs, whether there's more complexity with their medication regimen or some of those medical tasks, whether it's a feeding tube or there's wounds that need treatment. More assistance with major activities of daily living, like bathing, dressing, getting to the washroom, getting in and out of bed, getting to meals. So the complexity has gone up, and it may feel like this is something beyond what I feel comfortable managing at home. Or as a family, you're seeing your loved one struggling and you're saying, we're really feeling uncomfortable. We're feeling concerned that this is not sustainable. It also might be that if your loved one has some cognitive changes and you're concerned that dementia may impact their safety at home, or there might be a risk for wandering, that also might be a consideration for a transition into long-term care. It can be helpful to try to do some of the thinking about this outside of a time of crisis, but sometimes the time of crisis is what ends up prompting us to make a move. So again, there's no good time to do this. Some other things to consider as you're looking at long-term care are the appropriate levels of care. And I'm going to talk through those in the next couple of slides. But more broadly, thinking about if you're going to make a transition into long-term care, you don't want to have to make multiple transitions, one right after each other. It might be more appealing to transition into a lower level of care, whether that's independent living or assisted living. But we may realize that that's might be a little bit of a reach, that assisted living is kind of doable and kind of not doable. And we may realize that pretty quickly after that transition, we need to make another transition into a higher level of care, where it might be easier and harder because we have to bite the bullet and do it, but easier if we transition to that higher level of care at the very beginning to limit the number of transitions that need to be made. Sometimes we don't know until we get in there and we realize, yeah, no, this isn't the best spot. Sometimes we have a hunch and, it's just something to keep in mind. You also maybe want to think about cost and payer. And again, we'll talk through this a little more in the next slides, but certain levels of care, certain facilities accept certain types of payments. And so keeping that in mind as you're looking or as you're making decisions, both for initially, but also longer term. The location, whether you're close to the community where you are now, or whether you're closer to the community where you might be able to have more visitors or family in the area. Also want to consider religious or cultural preferences. Some of this may be around what services or religious personnel are in the building or offered, but also maybe around dietary preferences as well. So all reasonable to ask about and very reasonable to consider as you're looking at placement. And then the environment can be really important. Will you be able to maintain your doctors that you're familiar with? What are the activities like? What are the staffing ratios? How is the food? This is one of the most challenging things. Often people tell when we ask, how's the facility? The food's terrible. That's what I often hear. And it's not the same, which we have, food has a strong meaning for people. And so finding a facility that at least offers options, things that feel familiar, even if they're not quite the same, or allows family or friends to bring in outside food as well. So briefly, we'll talk about these different levels of care. So starting with independent living, it's basically like living in an apartment in a senior community. There may be a dining room or restaurant on site. There may be activities in an activity area that are offered, but people are pretty independent. It's just a community that might be 55 or over. So that's kind of generally what independent living. It's private pay, and there might be monthly association-ish equivalent to an association dues that you pay to be able to maintain your residency as part of that community. So then thinking about assisted living, these services really are varying a lot more than they were even 10 years ago when I worked in assisted living. You would have an apartment, usually with a kitchenette. You won't have a full stove, but you might have a refrigerator and a microwave. So you can keep maybe you can have breakfast or something in your unit, and there's a dining room that offers meals as well. And then they'll be able to provide weekly housekeeping services and some additional assistance with certain things. Generally, it's showers, but you can also kind of buy up or pick from a list of a la carte services, such as medication reminders or medication setup or things to escorts down to meals, things like that. But they may often charge for each of those additional services. So something to think about. They may offer you kind of a base that these are our monthly cost of living in the facility. But then when you go through all of the additional services and supports that you may feel more comfortable with or need to get put in place, it may add a significant amount to what that monthly cost might be. So kind of going in eyes open about that. Assisted living is private pay, so there are no programs that help support the cost of assisted living. Alternatively, supportive living facilities are essentially assisted living, but they're licensed differently in the state of Illinois. Assisted living is one type of license, supportive living is another type of license. These are licenses that are obtained by the Department of Public Health, and there are standards associated with that to be eligible under these types of facility names. And so supportive living, again, provides resident with their own apartment, or they may have a roommate. Meals are provided. They receive weekly housekeeping services and some additional support, maybe with things like showering or medication reminders. And then the difference is that supportive living can be paid for by Medicaid, which is the state public health program. And you may be eligible for both Medicare and Medicaid, and the Medicaid may cover the cost of your living facility while your Medicare is covering health. So something to consider as well. The next level of care is called skilled nursing facilities or skilled rehab. They provide 24-hour nursing care and assistance with all or any activities of daily living. And then residents generally may have their own room or share a room with one other person. And they have a lot of allied team members, such as physical, occupational, or speech therapists, a dietitian, a social worker, chaplain, visiting physician to kind of manage overall general health. Skilled nursing facilities can be either private pay or paid for by Medicaid or the VA. The thing to keep in mind here is skilled nursing facilities can be covered by Medicare for short-term rehab. So that's when someone's been hospitalized and then they need to go to the rehab facility for physical and occupational therapy. That stay is covered by Medicare up to 100 days, as long as people are meeting the criteria and making progress in order to justify their continued stay. But beyond that rehab stay, Medicare does not cover long-term care. So then the alternatives that do cover long-term care are Medicaid, the state-funded health insurance program. The Veterans Administration has some of their own facilities, or they may be able to, they have some contracted facilities as well that they're able to provide long-term care. Otherwise, again, we're considering private pay. And then in both assisted living and skilled nursing, memory care can also be kind of an added component. And so memory care provides supervised and structured programming for individuals with cognitive impairments. The staff may have received additional training both to support residents with cognitive impairments, also kind of manage any behaviors that might come up, whether it's some of the repetition in questions or wandering. The unit will be locked, so people can move freely within the unit, and you don't have to necessarily worry about people getting off the unit. Sometimes you have a little Houdini who lives on the unit and they have to be watched a little more closely, but generally people can walk around the unit without issues. And then, these are, again, most likely in assisted living, it's going to be private pay. And in skilled nursing facilities, you may find skilled nursing that also offers memory care. So that can be a consideration as well. So people often say, like, where do I start? How do I find facilities? How do I figure out what's available? The Medicare.gov website that allows you to compare facilities is here. And then, like I mentioned, the Illinois Department of Public Health license and surveys assisted living, supportive living, and I neglected to include it, and skilled nursing facilities. So you can find a list of all the facilities in Illinois on these websites. In addition to a list of facilities that are licensed by the state, you will also find the results of their surveys. And so for assisted living and supportive living, the State Department of Public Health goes in every 2 years and completes a comprehensive survey. And for skilled nursing facility, the state goes in for an annual survey. And all of those results are public record and are available on the website. The caveat being, the job of the surveyor is to go in and find things that are wrong. And so as someone looking through this data, you want to consider the severity of the things that are found. So is the refrigerator that keeps the medication off by a degree? Or is there a burned out light in one of the exit signs, emergency exit signs? Versus are patients having an outbreak of some kind of infection, and there was a unit that all got sick from maybe some infection prevention protocol that wasn't fully followed? Or are people getting missing doses of their medications? Something like that. So they're going to find things. If you find a facility on these survey reports that has 0 citations or 0 reports, I would also be very skeptical. No one should find 0. The surveyor's job is to find things. It's the severity of the things. So just keep that in mind. But these can be helpful too, helpful insights. You also want to go into the facilities and go and have a tour, talk to the admissions office, go for a formal tour, and then also drop in. You could go at an unscheduled time on the weekend or in the evening to see what it's like when they're not expecting someone to come by for a tour. You can ask to talk to family members. You can request menus, copies of the weekly menu, activity schedules. There's a lot of information you can get about the facilities. You can also ask for recommendations from the doctor's office, from the, if you had in-home services like home palliative care, for example, or home hospice care, those staff members are also going into the facilities. And so you can get a little better idea of what does it feel like from their perspective being in the facilities. So helpful ideas as well. Next, we'll talk about maintaining a safe home environment. And so some things to consider are completing a home safety evaluation. And this would entail having an occupational therapist come to your house to take a look at your environment and make any recommendations about how you could make that environment safer. Would it involve adding grab bars, or, the most common thing you've probably heard is pulling up area rugs, because those can be a tripping hazard. But it might be rearranging furniture, it might be modifying or recommendation to add a ramp, or a stair lift or something like that. But the occupational therapist can do a comprehensive safety evaluation and give you some ideas, places to start. It can be covered by the insurance. Home health agencies may provide a home safety evaluation. It might be a little bit more superficial, in the sense that they're looking at the bathroom and the main area where someone is, but they're not going in depth. There are also outpatient occupational therapy organizations in the Chicagoland area that are able to do a more comprehensive a home safety evaluation. And that would be covered by your Medicare Part B. So you can get a prescription from the physician and find one of those organizations as well. And then you might think about, based on the results of the home safety evaluation, what, if any, home modifications do you want to make? And some of these, like I said, can be as simple as putting grab bars in the bathroom, and some can be a little bit more involved, like adding a stair lift to make it easier to get up to the second level. You can even work with, there are architects or designers that specifically work with seniors, or how to make your home accessible, ADA accessible, were you to need to widen doorways or upgrade a bathroom. If you use a wheelchair, or potentially might use a wheelchair down the road and want to make some modifications now at this time, those designers can be a really helpful resource as well. There's even construction companies that have more experience doing some of these ADA accommodations as well. And then also thinking about mobility changes. So everyone's situation is different, and everyone's need for assistive devices may be different as well, but there are a lot of assistive devices available that can be really helpful to people. But recognizing that not all durable medical equipment, or what is often referred to as DME, is created equal. So, for example, if you have Parkinson's disease, there might be a specialized walker that's heavier, called a U-step walker, that might be more useful for you than a traditional walker. And that could be covered by your insurance. And so if that's the case, we would recommend you be strategic and use your Medicare dollars to get that heavier walker that might be more beneficial to you. Or if you're thinking about needing a wheelchair, getting a evaluation from a seating and positioning clinic under like the rehabilitation medicine division, to see what specific modifications would need to be made for you to make the wheelchair as accessible as possible, versus using your Medicare dollars to get the lightweight transport wheelchair. A transport wheelchair, just as a point of reference, is about $150 were you to buy one new, whereas a custom wheelchair could be a couple $1,000s, if not more. And so utilizing your Medicare dollars to get the more expensive equipment covered, and then borrowing equipment from a lending closet. We'll talk about that in another slide, but that there's still ways to get a lot of equipment and to try different equipment in your home to see what might make the most sense for you. So I should have led with this. Under Medicare, you can get durable medical equipment covered every 5 years. You can get a new piece of equipment. So, for example, if you get a hospital bed, you would be eligible for another new hospital bed in 5 years from the time you received the first one. There's also a little bit of an escalating kind of, they would cover a cane first, then a walker, then a wheelchair. But if you got a wheelchair first, then they're generally not going to cover the walker or the cane. So sort of thinking about being strategic and thinking about what you need. It might not even be worth the hassle of getting a cane covered by Medicare. In all honesty, you might think about the walker or the wheelchair. So considerations. And then just as a point to tuck away in the back of your head, hopefully you won't need this for a while, but if someone is going to transition into a skilled nursing facility, Medicare rules shift a little bit. And so especially with equipment like a wheelchair, and a skilled nursing facility is required to provide the durable medical equipment for its residents, but it might not be the exact type of durable medical equipment that would be recommended were you to go, let's say, to a seating and positioning clinic where they can fit you for your own custom wheelchair. And so if you're considering a move into skilled nursing, you would probably want to get any durable medical equipment ahead of that transition into skilled nursing. Get it covered by Medicare while you're still in the community, so you have that to take with you into skilled nursing. And then you'll be in a wheelchair. Let's say you're a tall gentleman and you want a wheelchair with a headrest. Well, get that wheelchair before you go into long-term care so that you're actually going to get one that supports your head and neck versus one that might be tall enough, but not as comfortable as it could be. That's just an example. So again, it gets a little complicated, but trying to maximize the benefits for you to make life as comfortable and also utilizing what's available to you. And so I mentioned lending closets. Many of the lending closets are available here. You can look to borrow separate pieces of equipment, and they can be really helpful to try things out at home. If you have a tub, a tub bench that might work better. So you don't necessarily have to go to the one in your community. You may be able to go to one in a neighboring community if they have the equipment that you want. You generally have to give them a deposit, but then you can have the equipment for up to 3 months or even longer. And then there's additional resources if you're thinking, if you have firearms and you want to think about like a firearm life plan or safety plan, who do you want those firearms to go to? If or when you're no longer able to have them, it's kind of like a will for your firearms. So this is a very useful resource as well. Okay, I lost track of time, so we're going to talk a little bit about mapping your journey, and this is specifically thinking about the documents that you want to have in place. So the majority of people say that they want a quality of life means that they want to die at home, that they want to have good quality of life and they want to stay at home as long as they can. But the majority of people actually die in hospitals or nursing home facilities. And so there can be a little bit of a disconnect. This is where, we're on these different levels. And the way to get from one level to the other to kind of allow our preferences and wishes to align with what the care actually looks like is we want to utilize legal documents to express our wishes and preferences to the type of healthcare that we want to receive, who we want to have make our decisions about this care, and telling people what kind of care we do or do not want. And so there's a few different documents that we may want to think about, and it's never too early to start to have these conversations. Honestly, having them earlier is better. So the first one we think about is a durable power of attorney for healthcare. It's saying who you want to have make your decisions. A living will is an opportunity to state what kind of care you do or do not want. And then if you decided there came a point in time in conversation with your healthcare providers that you did not want resuscitation or you did not want certain types of medical intervention, then you might fill out a POST, a physician order for life-sustaining treatment. And it's a shorthand of your living will that is the medical personnel are used to looking at, and it kind of very clearly and easily states what you do or do not want. And so the power of attorney for healthcare looks like this. You can kind of DIY it, do it yourself. You can find this a copy of this on the Illinois Department of Public Health website. It allows you to identify who you would want to make your decisions for you. It does need to be signed and by you, the person completing it, and witnessed. And it's recommended that it's not witnessed by someone within your family. And it cannot be witnessed by the person that you're appointing to make the decisions on your behalf. So it can be helpful to maybe consider appointing 2 people, a primary agent and a successor agent from 2 different generations. So a spouse or a brother or sister, and then is there an adult child or a niece or nephew, something like that. Another option is the living will. And like I was saying, this is an opportunity to say, I do want artificial feeding or artificial nutrition, which might be a fancy way of saying a feeding tube, or I do not want that. Or I do want dialysis down the road, or I don't want dialysis. And so there's a form, again, on the public health website that you can pull up and you can fill out, check kind of some of those standard choices. And then if there's some other things that you do or do not want that are more specific, you can write those in. And this is your responsibility to share with your healthcare team so that they know that you've thought about some of the things that you do or do not want. But this is kind of can inform a decision maker and your healthcare team should you need something like that in the future. If you need help walking through some of these decisions, the 5 wishes tool is really helpful, and it can walk you through each of these 5 kind of preferences, and it has additional steps within them that you can explore and questions, and might be helpful for you to both go through on your own and then can also facilitate conversation with family members as well. Additionally, the Conversation Project is a really wonderful interactive website. It has videos, it has worksheets that you can go through. It helps think about what are the questions that we want to have, what do we need to talk about, what are the things we haven't thought about that we need to talk about. So another nice resource. And you can make your living will as complex or as simple as you want to. And so just like when you go to have a baby, you can have a really explicit idea of what things are going to look like, or it can be as simple as you want to, when I went to go have a baby, I wanted a healthy baby and a healthy mom. And those were my expectations. So thinking about the living will as well. And then if there comes a point where you decide that you no longer want to be resuscitated, were you to stop breathing, or you want to limit the type of interventions that you receive, then you may want to consider completing the POLST form. It's called the MOLST in other states, but in Illinois, it's called the MOLST. And so the big thing is we need to have the conversations with your healthcare team, have the conversations with your decision makers, and then complete the advanced directives. Some of these advanced directives can guide the conversation. Some of them can come after the conversation has happened. You've had conversations and now it feels like, okay, we can go to these forms and fill them out. The MOLST or the POLST, is completed with the physician. It needs to be signed by a physician. And then you want to make sure that it's shared across your healthcare team. It's on this bright color paper, both so that in the hospital, it's easily visible, but also you want to put it in your house as well. So have copies of it, have copies on it on bright paper. And then generally the first responders know to look on the refrigerator or freezer, or in some communities in the freezer for a document like this. So that's why we want it bright colored. We want it visible in the event that we need it. And then additionally, you want to think about a power of attorney for property. So just like we were talking about medical care and what we want, we also want to plan for financial. And the power of attorney for property, there is a standard form available again on the Illinois Public Health website or Department of Revenue, I can't remember. But you might want to consider meeting with an attorney. Everyone's financial situation is different. Everyone's decision about what they want is different. And so having a consultation with an attorney to make sure that the documents reflect, again, who you want to have make your financial decisions, what type of decisions can they make, is going to be really beneficial. This document does need to be witnessed and notarized before it goes into effect. So something else to think about. If you need help doing some of these documents or figuring out where you find an attorney, the National Association of Elder Law Attorneys is a helpful place to start. Not every elder law attorney is a member of this organization, but certainly it can help point you in the direction to begin to find people. Okay, and then last but not least, developing a crisis plan. So what is a crisis plan? A crisis plan is an agreed upon plan of how to respond to a serious situation. And we want to have thought it through. Preferably it's written out, because in the event that I am not available to tell people what I want, having a document that they can refer to know what I want, or know who's next, who can pick my child up from daycare or school, or who my child's pediatrician is, or where they find the medicine, or, those kinds of things. Having it all written down is really important. And then you want to share it with the key stakeholders. You want to outline next steps, and you want to include critical information like those documents that we just reviewed, powers of attorney or advanced directives, medication list, who are other people that can be contacted, the name of the caregiver agency, and there's plenty more. You know your situation the best, but sort of thinking through what are the important details, what has to happen, or what is needed to kind of allow things to continue to function in your absence, whether you're sick or suddenly out of the country or unavailable or whatever the case may be. But just what do people need to know? Doing some of this planning and now can relieve added stress in the moment. A stressful situation is already going to be stressful, and we don't want the additional stress of then figuring out, oh gosh, now what do I do with my loved one that I've been caring for example. And so things to consider, like I was saying, everyone's situation is different. But what if your caregiver doesn't show up? Or what if you as the caregiver get sick, or you need to go to the hospital for whatever reason? Who can sit with your loved one? Is there a neighbor that can step in? Where you spent all of this time completing your advanced directives, where are they? Are they accessible? Are they at the doctor's office or your local hospital where you might be taken in the event of an emergency? Do your adult children or other family members or close friends have copies of them? Preferably electronic, but you could also put a copy in your glove box. I have a copy of my mom and dad's power of attorney for healthcare in my email. I hope I never need it, but I probably will. And the day I need it, I'm certainly not going to be able to get into their house and get into the middle drawer of my mom's buffet to find her important documents. I'm going to want to go to the hospital and figure out what's going on and be able to show the document on my phone, at least in the meantime. And then, is there a line in the sand? What if you are the caregiver and you're providing care to a loved one at home? Is there something that you feel, when would it be time to bring in additional care? Is there a specific task that you no longer feel comfortable doing? If your loved one begins to have difficulty with bowel incontinence, or there's a specific type of medical treatment that your loved one needs, only you can decide that. And it's okay to say there are certain things you can't do or you're not comfortable doing. I think that honestly, that's pretty brave to be able to say that. And then we think about, okay, then what is our plan if there are certain things that we're not able to do or don't feel equipped to be able to do? But thinking about that is kind of beginning our just in case plan. And then if you need help making this plan, you can meet with an attorney to help review your documents and make sure they reflect your wishes and preferences. You can schedule an appointment with a palliative care provider. They can help go through things like a living will, a power of attorney for healthcare, or even a post around the do not resuscitate or comfort measures or things like that. you can talk to a social worker for assistance. Many of them are connected to primary care doctors or in the community through the Department on Aging. And if you don't have someone that you can readily identify as being able to step in, you might think about a geriatric care manager or someone along those lines that can be that person that steps in the event that you need the additional support. And then additional resources, we'll make sure that you get these, but these are places to start to find out more information or what might be available to you in your communities. So with that, we will take questions. I know that I'm a little over time, so Jane, I know that there were some questions that came in that people had.
Indeed. Well, first of all, thank you for a very thorough and really expert presentation. You covered a lot of ground. And I know we had questions that were submitted in advance, as well as some questions that have come through in the Q&A section. So let's start with some that were submitted in advance. Here's one that goes straight to the point. What do you have to know as soon as somebody dies? What do you need to know? What do you need to do?
Yeah, this can be really overwhelming. If your loved one dies at home, certainly you want to be notifying the appropriate authorities. If they're on hospice care, it would be notifying the hospice agency. If they're not on hospice care, it would be calling 911. Because then you need the death certificate, and you're going to want to request several copies of the death certificate. There are lists online that you can actually find that will walk you through step by step. And I can share one of those so that it gets sent out with the notes from the presentation. But then you slowly need to begin to work through notifying people. Before any of that can happen, you really need those death certificates, because you'll need to notify the Social Security and the insurance, and begin to notify the credit cards and things like that. But you also want to think about, will there be a service, or what would your preferences be around cremation or burial? So those are probably come before you get the death certificate, and then you begin to think about the plans for a service or memorial, and how you would like your remains to be disposed of.
Very helpful, and I can attest to the importance of those death certificates. You need those copies.
Lots of them. Everyone asks for death certificates. You'd be surprised how many times well, Jane, you probably aren't surprised because you did this with your mom, but for the audience, you will be surprised how many people ask you for a copy of the death certificate. So,
yeah. So Sarah, you alluded to the fact that you would be sending out, is it a copy of your presentation to folks? Will they have available? Those were some great links in there. I know they're going to want them.
yeah, I'll share a PDF version of the presentation, because I know that there's tons of links spread through. So we'll make sure that gets sent or shared so it can be sent out.
Terrific. Questions around coping with being alone. Can you comment on that? Share your thoughts?
Yeah, I think there were some questions about coping with being alone. There were some questions about coping with aging and kind of thinking about some of these topics. All of them are really big topics. Sometimes it might be helpful to connect with a therapist or have someone to talk to, whether that's in the loneliness or around loneliness, or kind of grappling with aging, whether or not you have physical or medical changes, or just kind of the fear or anticipation of those coming down the road. But also with the kind of grappling maybe with the loneliness or isolation, some of it also might, with a therapist, you might be able to think about, how could you find ways to make connection? Where could you begin to find community again? And having a therapist or having that support as you begin to explore that and take steps to maybe put yourself in what might feel a little vulnerable or uncomfortable situations, going to an event where you don't know anybody, or thinking through how you could find other connections, a book club or other kind of craft or social or exercise, or all kinds of different things online. But it might be helpful to have support as you begin to try to work through some of that. And so that's where a therapist can be really helpful.
Thank you. I would imagine that there's some similar thoughts related to the emotions that come with aging. There's a few questions here related to depression that comes with getting old. Similar thoughts there? Would you add anything?
I think that what I might add is to find, if you're able to, if the depression is something that's impacting your day-to-day life, it's making it harder for you to get out of bed and do things that you once enjoyed doing. If it's making it harder because you're sleeping more, or you're losing interest in things that you used to do, you're eating less or more, then it sounds like the depression is probably impacting day-to-day life. And we also might want to think about treating the depression. The depression certainly can also be impacted by aging and thinking about the future, but we don't want to totally write that off and leave something untreated. That maybe we can address some of the underlying depression and then think about how else can we get some support about the future. And maybe that's, you meet with a palliative care doctor to talk through, here's medically what's going on for me. I'm scared about what my future might look like. And can you kind of help shed some light on what I might anticipate? Can you give me a little bit of guidance about what the future might look like? And you can kind of tell that provider how much or how little you want to know, but that may also be helpful if you're worried that something catastrophic is going to happen related to a diagnosis. And then you're able to go to the provider and they say, yes, I know you have this diagnosis, and I appreciate that this is your fear of what might happen. With this diagnosis, we often tend to see X, Y, and Z. And X, Y, and Z may not be that sort of catastrophic thing that you were imagining. So just sometimes information or getting a little bit of that outside perspective can be really helpful.
Absolutely. What we say is knowledge can be very powerful here.
Yeah.
Well, and I'll put in a plug for the Levy Center. Community is another very helpful resource with your fellow folks aging together. So take advantage of Levy Center activities as well. We have a question here. How can I help my husband talk about the future? Maybe there's some reluctance there. What would you say as advice?
Yeah. I think it's not uncommon. We can normalize it. I think there's some of those resources I was mentioning, the Conversation Project, 5 Wishes can be really helpful, but we may also want to normalize it. Sometimes when we're doing a power of attorney for healthcare with one individual, do both members of the family want to do it together? And this is just what we're doing. Like, we're all going to do our powers of attorney because it's probably a responsible thing that we all identify who we want to do or who we want to have help us make decisions in the future. Then in the same way, we can share what some of our preferences might be. My poor husband is very aware of what I do or do not want around some of the healthcare things. And he's like, why do you keep talking about this? I talk about it because, well, from my experience in my work, it's more normal, but having some of those conversations. Do you want to be cremated? Do you want to be buried? Sharing that with the people around you. And perhaps that can elicit from your loved ones, this is what I would want. Have you thought about what you would want? Is it something where you would like to go meet with someone to learn more about what our options are? We're starting to just begin to open those lines and have it be a little bit more destigmatized. And if you, again, a palliative care provider or your geriatrician may be able to help support some of those conversations too, or at least kind of kick off some of that for you.
Great advice. I love that. Normalize it. Let me turn to another question. When might it be necessary to change PCP from family practice doctor or internist to a geriatrician? What do you advise?
Yeah, I think that if you are satisfied with your PCP or your internist, you're feeling like they're listening to you, it seems like they're equipped to be able to address your concerns, I might stick with the person you have because it seems like they're equipped and able to address those needs. If you're feeling like that provider is no longer supporting you in the way that you're needing, either your appointments are feeling really rushed or more rushed than the healthcare system these days are making appointments, or you're feeling like you're asking questions and they're kind of being brushed off because, oh, that's just aging, or that's just normal at your age. That may not just be normal. That may be something that could be addressed, or there might be an option to alleviate that symptom. And I think that's when you might want to consider a geriatrician, someone who has more of that training or perspective that things aren't just normal because you're aging. And that would be my consideration.
Good insight there. Here's another one for you. How do you know when it's time to have or seek assistance with administrative matters?
I think there's a few considerations. One might be, do you want to do it anymore? And it's not, there are things that I don't want to do, but I have to do. There are some things that I don't want to do and I'm not doing because I don't want to do them. And that might be that if you don't want to do them and you're not doing them, they're getting more overwhelming to keep straight, or you're somehow getting more mixed up and more complicated as you're trying to work through it. That might be where it can be helpful to have another person helping. And so for the power of attorney for healthcare or the power of attorney for property, there is a way that those documents can go into effect either at the time of signing or and just kind of remain dormant until you need them. And they may then allow someone to step in on your behalf. So could your adult child then call the insurance and sort out one of these bills? And you're still capable of doing it, but it would be really complicated and it would probably get mixed up. And so your adult child is able to do that on your behalf. I think that's when you might want to start to think about it, and also get the perspective of others around you. If you think you're still doing everything fine and you're still capable of doing it all, but you're hearing from other people around you who care about you and know you well, that maybe there's some things that are getting missed, or maybe we are forgetting to follow through on some things, then that also might be a consideration. To have that outside perspective can be helpful, that we might want to have someone else helping us do some of these things.
Okay, great insight. You really want to just avoid when it turns into a real mess. Getting ahead of that.
Yes.
I'm going to take two more questions that were pre-submitted, and then we're going to turn to some that are online. So here's an interesting one. Is there a way to find out which assisted living facilities can accommodate vegan diets without calling each and every one?
Yeah. So I think that what this may or may not be the answer that the person who's submitting this hoped for. Any facility will be able to accommodate a special diet. However, it might mean that if you're vegan or vegetarian or gluten-free, that the choices that you have are far more limited. But all of the facilities will likely be able to accommodate it. It just might mean, what does accommodating look like at one facility versus the other? And so that's where you might narrow it down. If there are some facilities that you're interested in it might be then meeting with them individually and saying, okay, so I have your menu and I know that you offer choice, but realistically, if I'm a vegetarian or I'm a vegan, are you saying that my choice is peanut butter and jelly every day? I don't even know if that's vegan. I think that is. But, is that my choice? Are there, and a salad? Are there any other options that would be offered if these are my dietary preferences? So some of them may say, unfortunately, no. Okay, you narrowed that one out. Like they're not able to accommodate more. Some other ones might say, yeah, we have some other people who are vegetarian, and here's what we offer them. And the more people that we have in the building that are having these dietary preferences, like we've been able to offer more. So yes, you'll still have to go to the facilities, but as a blanket, if you called, they would all say, yes, we can accommodate it. But what does accommodating really mean? Same with, preferences around maybe kosher or something like that. They may say, yes, we can accommodate it, but what does accommodating mean? I think asking the next question and narrow down a little bit first to ones that you might prefer for other considerations, and then starting to think about what would the dietary preferences look like for the facility.
Sounds like visiting is a very good idea, just to get into it more specifically. Okay. Final question that was submitted in advance. You alluded to this earlier. Somebody is asking, what are the dangers of allowing children to take over all of your assets?
I don't want to come up with all kinds of different scenarios of what might happen. But I think when I read that question, what came to mind is there are ways that you can set up some guardrails or protections around assets so that, and I'm not an attorney, and I'm not going to pretend to be an attorney or an accountant or a financial planner, but if you're concerned about your assets being utilized in a way that feels consistent with what you would want or how you would want them to be allocated, I think it's meeting with those professionals to say, here's how I want my assets to be able to be used while I'm alive or after I die, or here's who I would want anything to go to, and I would only want them to be able to access it at a certain time, whatever the case may be. Then there are some mechanisms that can be put in place to reflect those preferences. And I would meet with the professionals to talk that through. Some of those DIY options, I would say you can do your own healthcare power of attorney for healthcare or for living will. But the power of attorney for finance or property, I think you're really meeting with a professional, especially if your situation is more complex, is going to be in your best interest. So, to this individual, it might be that yes, your adult child has access to your assets to help pay your bills, but that maybe there's someone else that's overseeing and keeping an eye on things outside of that individual as well. There's different mechanisms that can be put in place.
Great insight. It sort of sounds like the more specific your preference and maybe the more specific your concerns, the more planning you should do. Is that a fair?
I think that's the best summarization of that.
Okay. All right, good. All right, so let's look at some questions online. There's a question about construction companies that create accommodations. How do you find them, and how do you get a home safety evaluation done?
The construction companies, I'll include a link there's similar to the elder law attorney national organization. There's also a national organization for construction companies that do ADA accommodations. And there's also an association for architects that do ADA accommodations. So kind of searching for some of those national organizations, and usually they have directories of find someone in your area that you can then look for those resources. There are also home safety evaluations, you could Google outpatient home safety evaluation. And there are a few that I know about in the Chicagoland area that serve this area. One is called Moxie Home Health, and the other one is Vitalize Home Care. They both do home safety evaluations through your Part B benefit, and as well as home health companies. Though I think if you're looking for a more comprehensive one, using an outpatient occupational therapist who specializes in home safety evaluations will be your best bet.
Sounds like lots of options, and Google can really help. Okay. And a lot of specifics you shared. Here's one about state. If you have an advance directive in another state, do you have to do one in Illinois, or does one state document work across all states?
Yeah, that's a great question. So usually your advance directive will be honored from state to state. The consideration would be that these are state-specific documents. And so if you are able to update, if you are, moved to Illinois and Illinois is going to be your long-term home, you may want to update the document to reflect the Illinois document. The real, well, in my experience, the instances where it becomes a sticking point is if something is questions and it ends up going to court. And so if you have a document that is a Kentucky document, let's say, and we're in Illinois and it's gone to court, the Kentucky document may not hold up as strongly in court as an Illinois document. So that can be why it may behoove you to update documents if you're able. If someone has a cognitive impairment and is no longer able to update their documents, then you may need to stick with the documents that you have, because a document is better than no document. So,
Okay, very helpful. One of our participants is asking about pets. What do we do about our pets?
if you were to go into long-term care,
Assuming that that's what the question is.
okay. Yeah, I know that many people have a strong connection with their fur babies and not wanting to be able to make sure that they're taken care of as well. Most facilities, if you're going into assisted living or skilled nursing, do not allow you to bring pets. Independent living generally doesn't allow pets as well. Sometimes there are, under a certain pound limit that you can have, so smaller dogs or cats, but because of allergies and things like that, it can be more restrictive. So then I think it's starting to think about who might be able to, is there someone else in your family that might be able to take your pet, or a family member or friend? Or is there some way that you can have ownership over where your pet goes, whether you're donating them to a shelter or something that helps place pets again? I'm sorry, I'm not an expert in this. I wonder if there's even organizations that help place pets for seniors, if they're no longer able to care for them. But in that kind of crisis plan or thinking about the future, I didn't think of this, but this is a good point. Sort of, what would you want to have happen with your pet? Or if you had to go to the hospital, is there someone that would be able to come and feed your pet while you're in the hospital or in long-term, in a rehab facility? Certainly things to think about. I'm sorry, I don't have a good resource for that one.
No, it's a hard question. I think you did give a lot of good ideas. There's a couple of folks asking to see the last slide again. Well, how about we put that up in a minute, and then in the meantime, I'll ask you some other questions. But just know, folks who have asked for that last slide with additional resources, we'll post that up again.
Okay.
Next question is, how do we find the geriatric care manager?
You are going to sense a theme as I answer this question. Yes, I have a master's degree in social work, but I really think I'm a professional Googler. So there is also an association for geriatric care managers that you can, find. Again, that association, I can't remember their specific name, but if you Google geriatric care manager National Association, you'd be able to find it. And then they also have a lookup feature for members of that organization. But if you Google geriatric care manager, Evanston or Chicago North Shore, there are many in the community. I would also suggest, again, like word of mouth or asking at your physician's office or the senior center or other places where you're with other seniors or people in the community. Have you ever used one? Has anybody that you know used one? If you find some and you are curious, they can give you references, call them up, do an interview, learn more about their services, and ask for references, other people that have used their services, and you can talk to them and get an idea of, how is this helpful? What did they help with? But Googling, I'm sorry.
Google, well, hey, it's empowering. It's empowering. We're getting close on time. I have one more very specific question, and then would love to post that slide again. And you did say you will be sending a follow-up out. The one more specific question is about death certificates. Do they need to be hard copies? Can they be emailed? How do people handle that document?
So the official document is a hard copy, and it comes through the county clerk's office. So in Evanston, it would come through the Cook County clerk that offers birth certificates and death certificates. You can order them online and request the copies. And then I think it may depend specifically on who's requesting it. So if the bank is requesting the death certificate, will they accept a scanned copy? Or I might scan it for your records and, so that you have a electronic version, but then some of them might want it faxed because they're still dinosaurs. Or they might want, I say that because I work in a hospital and we still fax and we still use pagers. So we're in the dinosaur age too. But you might ask specifically what this organization wants, and they'll probably have their own preference. It might be that you can take it into the local branch of your bank. They make a copy of the death certificate. It's going to vary a little bit, but requesting the physical copy, you will get a physical copy from the county clerk's office. And that's where even request 4 or 5 so that you request more than you think that you'll need, because it's really annoying to have to go back when you've used all of them and your people are still saying, I need a physical copy, and you need to go get more. So save yourself that.
Got it. All right, Sarah, we're getting close to the hour. While you find that slide to post again, I'm just going to share a comment from one of our participants here who said, in Glenview at Arbor Terrace, you visited somebody who was in the memory care unit who had a dog and had to hire a dog walker, but they were able to have their dog. So maybe it's facility dependent what the rules are. It sounds like anyway in this example. Well, thank you for posting that, Sarah, and thank you for an excellent presentation and wonderful, very specific, helpful answers to help folks who are on this webinar. Sounds like you're going to do some good follow-up. We got to almost all the questions. A couple others may be coming your way, Sarah, for follow-up. And just a giant thank you. Well done, and very nice for Levy Longevity to have you as an expert. Much appreciated.
Thank you so much. Thanks for having me.
All right. Well, an excellent program. I think that's a wrap, and hope to see you all on future Levy Longevity series webinars.